I was talking with my mom on the phone a few months ago. She and my dad were driving to their town where they had their colonoscopy appointments the next day. They had gotten a hotel room and were going to go down a day early so that they could do the fun task of colonoscopy prep from a hotel rather than be on the road for it. See, my parents still live on this farm in South Dakota where I was raised, 18 miles from the nearest town, and that town doesn't even have a stoplight anymore. And so they make the 3-hour drive to the biggest town in the state several times a year to complete their routine evidence-based care like colorectal cancer screening. And this experience isn't unique to my parents. Many rural populations experience barriers to accessing and using research evidence that we know works to help detect disease early and prevent disease and provide the most promising health outcomes. Hi, my name is Chelsey Schlechter, and I'm an assistant professor in the Department of Population Health Sciences at the Center for Hope and at the Huntsman Cancer Institute. My research is focused on how we can make sure that we take our research evidence and make sure it reaches all populations, especially those living in rural areas, those living in poverty, and those who are uninsured. Some estimates indicate that it can take 17 years for just 14% of our research evidence to reach the populations that it was designed to benefit. My field of research is called implementation science. That means I study the methods for how we can bridge the gap between our research evidence and what we know works, and who ultimately benefits. One of the reasons why I love implementation science and the work that I do is that it's inherently a team sport. Our team at the Center for Hope aims to make it easier for patients and clinicians and communities to use research evidence. From here on out, you'll hear me refer to my research as the work that we do, and that's because implementation science can't be done in isolation. Critical to our team are our community partners. We conduct community-engaged research. That means that our research questions are driven by the priorities of our community partners, that we share resources like data and expertise and grant funds, and that the ultimate end users of our research, like the patients and the clinicians and the CHC leadership that are featured here in this photo, that they're involved in every step of the research process along the way. They're the experts in their communities. They know best what works to improve their health, and they educate us on that every single day. So how does a farm kid from South Dakota wind up here today? When I was growing up, being a scientist or a professor weren't jobs that I knew existed in real life, but I was fortunate enough to have an incredibly supportive family infrastructure and team of mentors to get me here today. When I graduated with my undergraduate degree from South Dakota State University, I moved to the big city of Manhattan, Kansas, to pursue a master's in public health at Kansas State University. It was there that my mentor, Dr. David Jeweltowski, taught me for the first time that research can take place outside of the walls of the laboratory and in the communities where we live and we learn and we work and we play. He also taught me about the translation gap between research and practice and set me up on my trajectory to become an implementation scientist. After graduating with my PhD, I moved to the University of Utah and joined the Center for Hope under the mentorship of Dr. David Wetter. I've learned so many things from Dave over the last 8 years, but one of the most important ones is how to build and lead teams of partners to solve big problems that are focused on improving population health, especially among those populations that are typically left out of or left behind of the research process. For the last 8 years at the Center for Hope, we've built a community-engaged research portfolio where we partner with state departments of health and primary care associations and safety net healthcare systems who serve the populations that are typically last to be reached by our research evidence. Our goal at the Center for Hope is to increase the reach of evidence-based interventions, what our research has shown us works. One of those evidence-based interventions is tobacco quitlines. Tobacco use remains the leading preventable cause of death and disability in the United States. And though we've done a phenomenal job of decreasing tobacco use over the last several decades, it's now become increasingly concentrated among populations with the lowest socioeconomic status. In the 1960s, when everyone and their doctor smoked, individuals with the lowest education status, indicated by the highest education status, indicated by the solid line here, and the lowest education status, indicated by this dashed line here, smoked at different rates, but they weren't that different. After 60 years of intensive public health interventions, we've successfully decreased smoking rates across all population groups. All of those lines went down, but we've now widened the gap between population groups, such that individuals with the highest education status smoke at a much lower rate than those with the lowest education status. And this is true nationally, but it's also true in Utah, where 12% of individuals with the lowest education status currently smoke, compared to just 2% of those with the highest education status. Now, there's a lot of reasons for this gap that I'm not going to get into today, but one of them is that individuals from lower socioeconomic status groups have a harder time accessing and using evidence-based interventions that we know work to help people quit using tobacco. Tobacco quitlines are one example of that type of intervention. They provide behavioral counseling and pharmacotherapy. They're an evidence-based resource that we have decades of research showing us that they work. However, they only reach about 2% of the population who could benefit each year. To try to close this gap, we partnered with several organizations in Utah to develop a research proposal. We partnered with the Utah Department of Health and Human Services, which provides the state tobacco quit line, now known as Utah Tobacco Quit Services, free of charge regardless of insurance status, the Primary Care Association in Utah, the Association for Utah Community Health, and community health center systems throughout the state of Utah. Community health centers provide comprehensive primary care to all individuals regardless of their ability to pay. You can see from this map that in Utah, they're located in geographically diverse areas. They serve populations that are urban and rural and frontier. In 2024, they served over 140,000 patients. Over half of those patients were at or below the federal poverty level, and almost 44% were uninsured. With these partners, we tested 3 strategies to increase the reach of the quit line. And we used a step care approach to this test, which means that we started with the least intensive interventions and then ramped up intensity of interventions over time if individuals didn't respond to the least intensive interventions. First, we changed the electronic health record at community health center systems to make it easier for clinic staff to ask patients about their tobacco use, advise them that there are free resources available, and directly and electronically get them connected to the quit line. If patients didn't enroll in the quit line following that clinical encounter, we then sent them proactive text messages for the next 6 months. These text messages included brief, informational, and motivational language and had a simple reply where they could get connected to the quit line. After 6 months, if patients still didn't enroll in the quit line, we then continued sending them text messages, but added the addition of health coaching calls from community health workers. These community health workers helped patients address motivational and also practical barriers to enrolling in the quit line. With these simple strategies, we were able to increase odds of enrollment in the quit line by 3-fold with the addition of simple text messages, and by an additional 2-fold with the addition of community health worker calls. We're currently testing strategies like these in research funded by the National Institutes of Health and the Centers for Disease Control and Prevention to continue our work on increasing the reach of quit lines and to increase completion of lung cancer screening and colorectal cancer screening. Additionally, building on this work, last year I was selected as one of 13 Cancer Moonshot Scholars to test these strategies for increasing reach of evidence-based interventions for lifestyle behavior change programs among community health center patients who have obesity. I'm here today because it shouldn't take 17 years for just some of our research to get to the populations that it was designed to benefit. And where you live, like the middle of nowhere, South Dakota, or the color of your skin, or how much money you make, shouldn't determine if you get to use our research evidence. I'm grateful my parents have the means and the motivation to complete their evidence-based interventions like colorectal cancer screening. My goal is that all communities and populations have the same opportunity. Thank you so much to my incredible team at the Center for Hope, my team of mentors, our community partners, and my incredible family. Thank you.